Okay, so good morning, everyone. Welcome to the lecture on abnormal growth. I think you have already had some lectures on normal growth patterns, and today we'll be looking at children who present with abnormal growth patterns, and especially we'll be looking at problems with height, that is short stature. So these are the objectives for today's lecture. You need to be able to look at growth charts and then recognize and describe if the growth pattern is abnormal, right? You should be able to recognize that this is a abnormal growth pattern and you should be able to describe it adequately. And secondly, you need to be able to identify, assess, and investigate a child who has short stature. This is an important component you should learn as a doctor before you pass out, right? So we'll be looking at aspects that every medical officer should know. And very briefly, we'll look at the causes of tall stature and overgrowth at the end. But that is of less importance. Right, so let's quickly look at normal growth patterns before we look at abnormal growth patterns. So you may have already learned that the time of most rapid growth is in infancy, right? So all of us would have been growing at the fastest rate during the first 18 months of our life. And during up to the second year of life, what usually drives your growth is the nutrition that you receive. So even at the time of birth, the intrauterine nutritional transfer via the placenta would determine your birth weight. So some of you may have had low birth weight, where your intrauterine nutrition that you received may have been suboptimal. Some of you may have had overnutrition, where the nutrition you received was excessive. So starting off life with a normal birth weight is actually a very good thing for your growth and future health. That is dependent on the transplacental transfer of nutrients. Then after birth, up to the first 2 years of life, your growth depends again mainly on the nutritional intake. So in previous modules, you would have learned about the importance of feeding during infancy. So we now recommend exclusive breastfeeding up to 6 months, and then we start complementary feeding. And by 1 year of age, you move on to an adult diet. So what this baby consumes will largely determine his or her growth, that is increase in length as well as increase in weight. In addition to that, a baby needs to be healthy. So good normal growth is also a very good indicator of good health. If a baby has a chronic disease, it will manifest as growth faltering or failure to thrive. So during early life, you are aware that our community health services do a very good job of monitoring the growth, weight and height of the babies using the CHDR. And if there is any faltering, then that indicates there is an issue in either the nutrition the baby is getting or the baby's health. So growth, which is specific to pediatric practice, is a very good indicator of your underlying health status as well as your underlying nutritional status. In addition to that, if you look at endocrinology, thyroid functions are thyroid hormone is the one which affects growth in the first 2 years of life. So there are other hormones which really help in your growth, but these come to play usually after the second year of life. And also your growth is dependent on the genes you receive from your parents. So whether you end up as a short individual or a tall individual, there are obesity-related genes which are multifactorial. So there are no single genes which affect your growth, or your height, your final height, or your final weight. But there are, it's a multifactorial aspect. And so the genes you get from your parent will also determine your final growth and your growth potential. But again, these come to play mainly after the first 2 years of life. So that is why we say during the first 2 years of life, you can actually manipulate growth to a certain extent, and you can optimize growth by making sure the child receives the correct nutrition and access to correct nutrition, maintaining growth which is optimal for this child. After 2 years, your genetic potential plays a greater role. And if there is failure to thrive, poor growth during the first 2 years of life, it is known as failure to thrive. Then we move on to the second phase of growth, which is the childhood growth. Now, this is the slowest period of growth. You know that we only grow during childhood. So once a child goes through the pubertal process and completes puberty, the growth is complete. So growth continues from fetal life up to completion of puberty. That is, with the fusion of the epiphysis, your growth, your height increase stops. So there are 3 phases: infancy, childhood growth, and pubertal growth. Out of these 3 phases, the period of slowest growth is during childhood, but it is also the longest period of growth. So though the growth is slow, the height gain you receive starting from 2 years of age till the onset of puberty is quite substantial. And usually children grow between 5 to 7 centimeters a year during this time. We'll look at the height velocity charts shortly, and we can look at these values a bit more. But just to go through as an overview, childhood growth depends again on good health and adequate nutrition. In addition, we have the hormones playing a much bigger role during childhood growth. So growth hormone starts playing a vital role, as well as thyroid hormones and other hormones such as adequate insulin and glucocorticoids also play a role. So if a person is receiving high dose prednisolone during childhood growth, that will inhibit this person's linear growth. If they are insulin deficient, this will mean that they are not absorbing glucose. So there's a lack of nutrition, and there'll be weight loss if a child develops diabetes, for instance. And finally, vitamin D also plays a role in bone growth and bone health. So this is a slow period of growth, and if there is any abnormal growth during this time, that would indicate either a problem in their health status. So it could indicate an acute illness or chronic illness. It could indicate problems in nutrition, undernutrition leading to stunting, or overnutrition leading to obesity. Then growth hormone deficiency and hypothyroidism are associated with short stature. Excess glucocorticoids as forms of medication leads to short stature, and insulin is needed for weight, right? To increase weight, you need to absorb the glucose from your meals. And finally, vitamin D affects your bone growth. Then after that, we enter the phase of pubertal growth. Now, during puberty, all the previous factors are working, and in addition to that, the gonads, that is ovaries in girls and testes in boys, they start producing sex hormones. So sex hormones, testosterone and estrogen, are also drivers of bone growth. And this leads to a very rapid growth. The second highest rate of growth occurs during puberty. So puberty leads to an increase in bone mass and length, as well as lean muscle mass. So in boys, especially testosterone increases their muscularity, and in girls it leads to adipose tissue deposition as well. And so you see gender differences starting to develop during puberty, with differences in their body composition as well. So this is a height velocity chart. So when you look at a height velocity chart, the x-axis has the age in years, and the y-axis has your height velocity in centimeters per year. So to calculate, so for instance, if you take an 8-year-old child, the average height velocity is 5 centimeters a year. This is just a very simplified version. In a proper growth height velocity chart, you will have centile lines. What is shown here is, I think, the 50th centile, right? But this is just a simplified diagram to show you that a 1-year-old will be growing at about 12 centimeters a year. A newborn may be as rapid as 18 centimeters a year. Every year you will have a decreasing in your rate of growth. By about 5 years, you start reaching this slow childhood growth rate, which is about 5 to 6 centimeters a year, which continues till you start entering puberty. So girls enter puberty before boys, and that is why the broken line is for girls. You can see by about 11 to 12, between 11 to 13 years of age, most girls will have an increase in their growth rate, reaching up to about 9 centimeters or more a year. And then finally, by about 14 to 15 years, they stop their growth altogether. So this signifies the achievement of final adult height. So after about 15, 16 years of age, you will not increase in height afterwards. In boys, the puberty growth spurt shown in black occurs later, maybe starting by about 13 years of age, and peaks at about 14, and then starts coming down, the rate starts coming down. By about 17, 18, the growth rate falls down to a low level. Right, so this describes the patterns of growth during normal childhood and adolescence. Right, so we are very fortunate in Sri Lanka that all the children carry with them a child health development record which carries growth charts. All of you should make yourself very familiar with the growth charts available in the CHDR. So these will be given to you even at your final pediatrics exam. These are the charts we expect you to be familiar with. If you have gone for your pediatrics appointments or at least done your introductory pediatrics appointment, you will have looked at these, I hope. And so you have different charts for different ages. Now this shows a growth during the first 5 years of life for the height. So you would expect, so a child growing along a centile line. For instance, let's take the line between the dark green and the light green zone, which is the -1 ST line. If a child increases in height along a centile line, that means this child has normal height velocity, because these charts are made to reflect normal height velocity. So you don't even have to go back and check on a height velocity chart. For instance, if you take a child, this is first birthday, second birthday, So between the second birthday and the third birthday, this child would grow from here to here, right? So that's from 82 to 90, 82 to 90, that's about 8 centimeters a year. And you would find that this is a normal height velocity on the height velocity chart. So these charts, the angle of this will correlate with the height velocity you will see at a at the same age. So you don't have to use height velocity charts. You just need to plot the child's height at adequate intervals on the chart and make sure the child is growing along a centile line. So these growth charts are very, very helpful to recognize so the child is growing normally and to recognize abnormal growth early. So with that, let's move on to patterns of abnormal growth. Now these are 3 charts which shows different patterns of children who have short stature during childhood. I'm just putting this as an introduction to show you. So if you look at the first chart, don't worry too much about the diagnosis. You see the top chart shows the height or stature, and the bottom chart shows the weight. And the x-axis is age and the y-axis is height. So this child is growing below the norm during childhood, but at the last few years, he seems to catch up and he reaches his final target height, right? So this is a child who is short during childhood, but ends up as an adult with normal height. So which is not too bad. So during childhood, they may have some issues, but as an adult, they have a normal height. When you look at the second chart, this child starts off height in a normal range, but as time goes on, starts deviating away from the normal, becomes short and ends up short, right? So the target height is also a little bit low and he ends up within the target height, but short for a normal person. And the weight in both these are a little bit, in this first instance, a little bit below normal, but catches up and ends normal. In the second instance, it's a little bit below normal and remains below normal. And then you look at the third graph, this is a child with either chronic illness or nutritional deficiency. So they start off early life okay, but then start deviating and goes further and further away from the normal line and ends up short. The weight also deviates significantly and they end up as a thin, short adult. Right? So these growth charts are very helpful because they give us a lot of useful information about when an abnormality starts, and sometimes we can predict how it's going to end. Right, so let's do a quick question. I want all of you, if possible, to take out a pencil or pen and a piece of paper, scrap piece of paper, and or your tabs, and just list 3 abnormalities that you see in this growth chart. So you can see this is a growth chart for boys between 2 to 20 years, right? It shows stature for age and weight for age. Stature or height is shown here. This side is inches, this side is centimeters, and this is weight. This is not the typical chart that you will be given for exams and what you will see, but I just put this as an example, right? And so you can see these dots. So please remember, when you're marking heights and weights, you have to mark them in this manner, in a little dot. Please do not put circles around these dots. I don't know from where you learned that. Do not put circles around dots because then you can't see exactly what is happening. Just simply put a dot like this. So this is the height of the child and this is the weight of the child. So you can see we have recordings from the 4th birthday on to the 8th, up to 8.5 years. So what I just want you to appreciate is what happens from the 4th birthday up to 8.5 years, what happens to this child's height, what happens to his weight, and there are other things which I want you to notice around the periphery of the chart. Let's see how whether you all pick it up. So please list 3 abnormalities you show or in this growth chart. I'll give you a few minutes to do that.
Excuse me, madam.
Yes.
We can split the video now, I think.
Sure. Can you see the screen now?
Yes, madam.
Right, great. Put your hands up when you finish. Just use the chat to put your hands up, and I know. Oops, oh dear. Okay, have you all finished? Okay, I think that's enough time. So let's look at what you wrote. Okay, so these are the things I wanted you to appreciate.
Madam.
Yes.
Madam, the recording hasn't started.
Thanks. Right. Okay. Great. Thanks. Yeah. Right. Okay. So let's look at the answers. So I hope that you all appreciated that this child starts off with a height which is in the normal range on the 10th centile, right? So this is the 10th centile line. But by the next birthday, by 5 years of age, he's on the 3rd centile line, and then he's gradually falling below the 3rd centile line, and he ends up below the 3rd centile line. So one of the abnormalities is this, that his height is crossing centiles downwards. You should actually write downwards, right? And his current height is actually not in the normal range. So it's below the 3rd centile. And did you all notice this mark here, mid-parental height? MPH stands for mid-parental height. So this is what you would expect, and we'll look at how you calculate that. This is his genetic potential. Depending on his mother and father, this is the height you would expect him to be. So actually his height he should be growing along the 10th to 25th lines. Though he starts off somewhere there, he is now deviating downwards below his centile genetic potential as well, right? But if you look at the weight that started on between the 10th and 3rd and 10th centiles, and he's gaining weight along that line. So he's not becoming thinner or he's not becoming fatter in a sense. His weight is okay, but he's not growing in height as much as you would expect. So you expect a child to grow along the centile line, but here you see him crossing centiles and ending up below the normal range, 3rd centile. And if you look at his genetic potential, it's also below that. So those are very important factors that you need to start looking at and noticing when you interpret, to recognize and interpret abnormal growth. Okay, so let's move on to abnormal growth. And what I want to talk to you mainly today is about short stature, right? Now, this is how you define short stature. It's a height below the -2 standard deviations, which correlates approximately to the 3rd centile. It's actually the 2.3 centile, below the mean for age and gender. So mean means the 50th centile, and age and gender. So you have to make sure that you use the correct age based on the date of birth. It's better to ask for the date of birth of the child and calculate the age in years and months so that you can plot it at the appropriate age, at the correct age, and make sure you use a gender specific. So that there are separate charts for girls and boys. You have to make sure you get the correct gender chart and check the age based on the date of birth. You can get the date of birth from the CHDR itself. These are very important facts, don't forget, right? And then you plot, you measure the child's height and you plot it. So if this falls below the -2 SD line, then by definition, this is a child with short stature. So adults can also be defined by this. So at 18 years of age, if you plot them, that's their final adult height. So any of you can plot on the CHDR chart at 18, at the edge, which is the 19 years of age, and see whether you fall below the -2 SD line, where you will, by definition, you will have short stature. So when you take children who have short stature, according to this definition, majority of them will be normal. I mean, will be healthy. What I mean is healthy, although they are short. So now 90% of children who fall under the definition of short stature, and I'm talking about children where they have growth potential left, they will have what we call non-pathological short stature or physiological short stature. It's not due to some disease condition. But if you are very short, the more you deviate from the minus 2st line, the shorter you are, then the more likely it is that it is a child with a pathological cause of short stature. So by this, you will understand that children can be short due to a pathological cause or a non-pathological cause. And majority of children, about 90%, will have a healthy, will be healthy and they will have a non-pathological cause for short stature. But if you are very short, then we start thinking whether there could be another cause. So anyway, if a child falls within this definition, if their height is below minus 2st, we have to evaluate them and do at least some investigations evaluating them for short stature. So this is very important, and this is something that we expect all of you to do when you have passed your final MBBS exam, right? So it's very important to concentrate on this. Now, the first thing you have to do is you have to be able to take a correct height assessment. So after 2 years of age, you can get the child to stand and do the height. Before that, they are not capable of either they are not capable of standing or they are not capable of understanding or command so that they can stand according to the instructions which are necessary. So up to 2 years of age, you measure the length. So it's not the height, then it's the length by using an infantometer. When you have your skills session, you will have hands-on practice with mannequins measuring the length of a child on infantometer, and you can measure your own height or that of a colleague using a stadiometer, right? So there are 5 points that you need to ensure. The heels must be touching the board, you must be barefoot, the knees must be straight, the back and back of shoulders must be touching, the back of head must touch, right? And the head has to be level, and you just put some gentle upward traction on the mastoid process. Tell the child to take a deep inspiration and then exhale, and you check this in mid inspiration. So all those criteria are essential that everyone gets the same height, right? So anyone who measures should get a similar height. So you pull down the stadiometer and get the reading from here. So the first step in evaluating a child for abnormal growth is getting the correct measurements. So up to 2 years, infantometer and the length. After 2 years, the standing height. Sure, you would have already had lectures on these. Then when you plot it on the chart and you see whether there are any problems. So in this regard, if you see a child is short, then these are other important measures which are very helpful. So the child is very likely to be accompanied at least by one parent, hopefully both parents. So you should measure their heights as well. So as they are adults, you don't need to bother with their age, because after 19, you can use a chart at 19 years of age for females and males. Make sure you check on the correct chart, and you can check their heights first. And using those two heights, you can calculate the mid-parental height, which we will discuss. And also, if there are any siblings, it's helpful to have the heights of the siblings, because they also have the same genetic potential, because same parents, if they're from the same parents, then you have some controls at different ages, children of the same parents, and you can compare this child's growth with the growth of the siblings. Have you all learned how to calculate the mid-parental height previously in lectures? Do you know how to measure the mid-parental height?
No, madam.
You haven't. Okay, right. So I'll teach you that. Then, right. Then, so you measured the height of the child. If you think there's something wrong, you have measured the parents as well, and then see whether there are previous growth records. So then it's very helpful to assess. We can also look at the growth pattern of this child. So if you see a child who is 4.5 years of age, then you can plot it here. And you can, if there are previous measures, you can see how this compares to his previous growth. So you can observe his height pattern. And if you have a previous measure, you can also calculate the height velocity. I'll tell you how to do this. So height velocity, how do you calculate height velocity? It is the difference between two measurements, two height measurements taken at least 6 months apart, and then you adjust it to centimeters per year, right? So to be normal, this is a height velocity chart. I told you I only showed a simplified version. So this is a height velocity chart for boys, which shows the this is the 3rd, 10th, 25th, 50th centiles, right? Like that. So all the centiles. And so to be normal, the height velocity actually has to be between the 25th to the 75th centiles. Right. So that's not that important for you all, but just to explain. So you take two measurements at least 6 months apart. If you take them very frequently, then you can make errors. So the recommendation is they have to be at least 6 months apart. Say you have a measurement taken 8 months ago, right? So 8 months ago, he was 100 centimeters, and today he is 105 centimeters. So he has grown 5 centimeters over 8 months. So what you do is, you take that difference, which is 5 centimeters, and you divide by 8, which is the months between these two measurements, and you multiply by 12 because there are 12 months in a year. So by that you can get the height velocity in centimeters per year. So it doesn't have to be measured exactly 1 year apart or 12 months apart. Whatever height measurement, if it has been measured before 6 months of age, the gap is 6 months or more, you can take those two measures, divide by the gap in months between them, and multiply by 12 to get the height velocity over that time period in centimeters per year. So if you have the height velocity between 3 years and 3 months and 4 years, then actually you plot it somewhere in between, right? So between these 2 points, you can check and see whether it is normal. Right, so that's a little bit about height velocity. And the other thing which is important, which you can measure, is the upper segment to lower segment ratios. Now, this is also an important measure. We usually don't do it, but it's very helpful in a child who has short stature. If the child doesn't have short stature, you don't have to worry so much. Or if you think a child looks abnormal, like a child with a syndrome, and doesn't look very normal, it can be a problem in their body proportions. So what you do is you know how you measure the normal height using a stadiometer. You get the child to stand to a side and you pull that stadiometer down to their pubic symphysis, right? And you get the measurement from the floor to the pubic symphysis. So your standing height is from the floor to the top of the head. That's your usual height. And then you pull down the stadiometer down to the pubic symphysis by getting the child to stand at a sideways. And then with that, the reading you get is the lower segment. So now you have the total standing height and you have the lower segment. So by subtracting the lower segment from the total height, you can calculate the upper segment. And you look at the upper segment to lower segment ratio. Now this is very important. There are few things. If you have a pen and paper, you can write these down. So when a child is born, this upper segment is much bigger. Little babies have short limbs and a large head, right? So the upper segment is 1.7 and the lower segment is 1. So the ratio is 1.7 to 1 at birth. And then, so there are only 3 measures I want you to remember. At 3 years of age, it's pretty easy. It's 1.3 to 1. So between birth and 3 years of age, where you have that rapid growth, the children will grow in their axial skeleton, right? Their vertebral spine will lengthen, but more than that, their limbs will start lengthening. So if you may remember, if you look at a little baby and then look at a 3-year-old, the limbs are much longer. So this segment changes from 1.7 to 1 at birth to 1.3 to 1. And then it becomes equal, 1 is to 1. So, for instance, if you have a 100 centimeter child, this will be 50 and this will be 50, right? So there's differential growth. And by 7 years, your upper segment to lower segment ratio is 1 to 1. And this kind of continues till puberty. During puberty, your limbs actually lengthen even more than your trunk. So its upper segment is 1 and the lower segment becomes 1.1. Right? So there are only 4 figures. If you're interested, you can remember. At birth, it's 1 to 7. At 3 years, it's 1.7 to 1. At 3 years, it's 1.3 to 1. At 3 years, it's 1.3 to 1. At 7 years, it's 1 to 1. And after puberty, it's about 1 to 1.1. So the limbs are slightly higher. So if you are interested, you can measure your own segment. It should be roughly about 1 is to 1 or 1 is to 1.1. Right, so this is important and I'll explain it to you later. There's another thing, so this is called disproportion. If you say that you see a 8-year-old child who's actually the upper segment is much longer than the lower segment. So 1.4 to 1 at 8 years of age. Now that is what you call disproportion. Their proportions are not normal. There is disproportionate short stature. Similarly, you can take other measures like sitting height. You don't need to know too much about them, right? So you take the sitting height, you need to have a stool which is exactly 50 centimeters. We don't have that in the ward, so we don't do this, and you need to have special charts to interpret these. So you can check for disproportion. But let's go back to our...
Excuse me, madam.
Yes.
Madam, the time
is... Okay, thanks. Is it clear up to that point? Are you all with me? Any questions up to that point? Please raise your hand or send. I can't see the chat window. Yeah. Can send any questions on chat? Is it clear up to that point?
Yes, madam.
Right, okay. So we'll move on. Right. So then what you do is you plot this child's height on the appropriate growth chart. So this is a boy and you have measured him at 8.5 years. So or if you measure him at 10 years, then you plot it against the correct height, correct chart, right? Correct gender, and you just mark it with a spot. Now this is his mid-parental height. So I'll tell you how to assess the mid-parental height. And then we can assess, according to the mid-parental height, you can see this child is too short. The other thing that we do is we can assess their skeletal age. So I told you after about 14 to 16 years, we stop growing. Now this is because there is this growth plates have fused. Now, if you look at this, the last X-ray here, there is no growth plate. The cartilage at the edges of the bones have all fused. So this child has very little growth potential left. But if you look at the other charts, there is a space, can you see, between the metaphysis and the epiphysis, there is a translucent line. This is the growth plate. So cartilage is being put down to both sides, and this child will grow. Likewise, in all the long bones, there is height potential left. So very young babies, they just have the metaphysis, and then after a while, they start, epiphysis starts calcifying, and it becomes different shapes, and then they grow, and finally this gap fuses. At the end of puberty, estrogen causes the epiphysis to fuse, and then you stop growing, right? So what we do is we ask for an X-ray of the left wrist and hand, non-dominant, but usually we take the left anyway. And there are books, bone age books, which are like atlases. So you match the X-ray with the bone age you have, and you get a rough estimate of the bone age. So that you don't need to know, right? You can get a radiologist or endocrinologist to do it for you. So let's look at the causes of short stature. Now, the majority of children, I told you 90%. So if you go for a school medical inspection in your school and you check all the grade 4s, you may find about maybe 20 children who are below the 3rd centile. So if you take that 20, only about 2 will have pathological short stature, whereas about 18 will have these 2 non-pathological causes of short stature, which are called constitutional delay in growth and puberty or familial short stature. The other causes for short stature, the pathological causes for short stature, are given below. So those are chronic undernutrition, right? If you don't have access to food. Chronic diseases, notably diseases which can not be picked up and just manifest with short stature are very important. So renal insufficiency, chronic kidney disease can manifest as growth failure, short stature, the first instance. Then children with diseases like liver failure, heart failure, or if they have some immunodeficiency and they're getting infections every few months, like pneumonias, diarrheas. If you have chronic anemia, if you have very poorly controlled bronchial asthma, you are wasting a lot of your energy on breathing, right? All these chronic diseases, you will not be growing properly. In them, you will be short and you will be thin as well. If you have underlying disease, you will be short and thin usually, unless you are on treatment with steroids. Right. Then these are the other causes of pathological short stature. They are endocrine disorders. So disorders like, I think you have already completed your endocrine module. So you have learned a little bit about growth hormone. So growth hormone deficiency, or you have your growth hormone receptor is mutated, like growth hormone resistance. Then hypothyroidism. If you are on excessive steroids, which is called Cushing's syndrome, or if you have vitamin D deficiency rickets, all these endocrine causes leads to short stature. And you also have some syndromes which are associated with short stature. So the very classic cause of short stature, syndromic short stature in girls is Turner syndrome. Again, they may present to us. The first presentation may be with short stature. Then there are other syndromes like Noonan syndrome, Silver-Russell syndrome, which also very cause quite significant short stature. Then all of you, I'm sure, must have seen people with achondroplasia or hypochondroplasia, right? You can see them in the normal community because they are not sick, they are within the community. So those are called skeletal dysplasias. They have a problem in their bones which make them grow poorly. And lastly, there is something called psychosocial deprivation, where you lived in a very deprived home front, where you can also have growth failure and short stature. So those are the causes for short stature, right? So you have the non-pathological causes, which are constitutional delay and familial short stature. Then you have chronic disease, which can include chronic renal failure, organ failures, anemia, recurrent infections, chronic malnutrition, right? Anything like that. Then you have the endocrine disorders, you have the syndromes, you have the skeletal dysplasias, and rarely psychosocial deprivation. So those are the main categories which lead to short stature. Now, within brackets, I have given you the bone age. What happens to the bone age in each of these conditions? Now, there's an easy way to remember this. Right? There are certain conditions where you are born with a low potential to reach a normal adult height. And in those situations, your bone age is usually normal, right? Your bone matures at the correct age, but so the bone at 8 years, your bone age is 8 years. But you are short. Now, those causes I have written as normal bone age. So if you look at the non-pathological causes of short stature, familial short stature, you have a very short parent or both parents are short. Even at birth, we know that the genes of this child will determine this child is going to be short. So it's nothing to do with bone, nutrition or anything like that. So when you have familial short stature, you have a normal bone age. The other conditions where you have a normal bone age are the syndromes and the skeletal dysplasias. Again, if you're born with the Turner syndrome genotype, then you are going to be short. However much you eat, however healthy you are, otherwise you're going to be short. So in those conditions, you don't have a bone age delay, you have a normal bone age. Same with skeletal dysplasias. If you have a genetic defect in your bone, genetic bone disease, it's nothing to do with maturation or inadequate nutrition or anything like that. It's something intrinsic to the bone. So it's not a thing with bone maturation. So you have a normal bone age. So the three main categories where you have a normal bone age, though you're short, are problems, intrinsic problems, genetic problems. So those are skeletal dysplasias, syndromes, and familial short stature. In all the other causes, there's something wrong from the outside. There's nothing wrong with your bone per se, but you don't have the ideal conditions to grow properly, right? So let's leave aside constitutional delay for the time being. That also has a delayed bone age. So when you look at the picture of the bone, you can get someone to do it, a consultant, and then look at the actual age of the child, what we call the chronological age. The bone age is less than the normal age of the child. So the conditions where you do that is constitutional delay in growth and puberty. This child is constitutionally a slow grower. There's nothing wrong with this child, but he's growing or maturing more slowly than others. It's a normal variation. So their bone age reflects their height age. So for instance, you may have a 10-year-old whose height is about that of a 9-year-old. And his bone age also will be 9 years. And he'll be a slow grower. He will go into puberty also a little bit later than his peers. Right? So that is what you call constitutional delay. There is no reason for it. Then you have the other disease conditions. Right? So you will be short and your weight also will be affected because you're not getting proper health, you don't have good health, or you don't have good nutrition. So things like chronic nutrition, and these organ failures, anemia, asthma, right? You can't, your body is not growing properly. So everything is delayed. Your bones also mature late. So your bone age is delayed. Something is wrong. You're not growing properly. You're not, bone age is also in the same way not maturing properly. Same with endocrine disorders. You need growth hormone for proper growth. It's an outside factor outside your bone. Thyroid hormone, you need it. You don't want excess steroids in your body. That's not good for your growth. And you need adequate vitamin D to grow. So those are outside factors outside your bone that you need for optimum growth. In all these endocrine disorders, therefore, you have delayed bone age. And in psychosocial deprivation also, you don't have that optimal nurturing conditions to grow properly. Therefore, you get a delayed bone age, right? So I hope you remember, I don't want you to have to memorize it too much. If there's something intrinsic with the bone, you have a normal bone age. There's nothing wrong with the surrounding factors. But if there is something wrong in the surrounding factors, exogenous factors, then you have a delayed bone age, right? So then the other concept I wanted to teach you was disproportionate. Usually, though you're short, say you're a short 9-year-old, your upper segment to lower segment should be 1:1. But if you're a short 9-year-old and your upper segment, your lower segment is much shorter, right? So your upper segment is 70 centimeters and your lower segment is 30 centimeters. That's very abnormal. Your limbs are more short. So in those conditions, these are the three main diseases. So what helps us is if we do this simple measurement and we find that a child has disproportionate short stature, it really narrows down our diagnosis. So then the causes for disproportionate short stature are the skeletal dysplasias, things like achondroplasia, where you have shorter limbs than your trunk. Both are short, but your limbs are short. So skeletal dysplasias are classic conditions which lead to disproportionate short stature. Same with rickets, right? And untreated hypothyroidism. Severe untreated hypothyroidism, rickets, and skeletal dysplasias. These are the three conditions which, at your level, you need to know which lead to disproportionate short stature. Right, so with that, let's look at, I told you I'll tell you about the target height and the mid-parental height. I'm sorry, I thought that you would have learned about it. So let me explain briefly. Let's look at a child with constitutional delay in growth and puberty. Now, this is a child who is a person who is late to mature. He starts off life, look at his height, he starts off life with a normal height. And this is his parents' genetic target. But by about 7 years, his height starts to fall below. Now he's on the third centile, now it's falling below the third centile. Third centile is more or less equal to the -2st. So now he is short. So he's from about 7 years of age to about 15 years of age, he is actually pretty short. So, and you can see that the difference between the normal height and his own height is the worst around 13 years of age, right? So what happens is, I told you, in constitutional delay, he's just a late maturer. So his born age is actually a little bit younger than his age. So I will go through the puberty lecture with you in the afternoon, and then we'll go through this again, right? So it will be clearer. But what happens is, his peers start puberty when their born age reaches the age of puberty. But because he has a delayed born age, this boy doesn't start puberty, and then his friends, his peers, his classmates start growing at a rapid rate, but he's still growing at his slow childhood rate. So that when his friends start puberty, this is when most boys with pubertal delay and constitutional delay present to us, because they are now significantly shorter than their peers. But they do go into puberty. Can you see his pubertal growth spurt starts here? at 13 years, when most of his friends have started about 12 years. And then he does catch up. He catches up with his peers, and then he continues to grow while his friends almost stop growing here. Right? By 16, you can see most children will be growing like this. But he continues to cross up and he reaches his mid-parental height. So he has a delay in maturation. So this is called, we don't have a reason for that. We think it's a normal biological variation. There's constitutional delay in growth and puberty. Lots of children who present with short stature can have this. All they need is reassurance and follow-up. They are otherwise healthy. And so I will talk to you about the target height or the mid-parental height. Now, what I would like you to do as homework, and I will look at the answer in the next lecture on puberty. I would like you to look to obtain your parents' heights, your mother's height, your father's height, and your height, right? I hope you can call and you know it already, or you can get it, or if you can't, just take a patient's, if you have a patient's height or your colleague's height, it's okay. And then see whether you fall within your mid-parental height. Now, how do you calculate that? If you are a male, then your father's height, you can get it exactly as it is. But your mother is a female. So there is no point taking a female height onto a male growth chart. So what you need to do is you need to add 12.5 to the mother's height. Now this is the average difference in heights between females and males in our population. So some Western textbooks may say 13.5. So if you take average male and female in the Sri Lankan population, average male is 12.5 centimeters taller than average female. So you add 12.5 to the mother, you keep the father's height as it is, and you take the median of this, right? So you add them up and you divide by 2. This gives you a single value. This is your mid-parental height. So for if the mother is 150 and the father is 160, it's not 155. It depends on the gender of the child you are assessing. If you are assessing a boy, you add 12.5 to the mother. So you get a higher figure. If you are assessing a girl, you reduce 12.5 from the father and you get the mean, right? So genetic potential for females and males obviously are different in the same family, right? So this is how you assess the mid-parental height. So you get a single value, and that is what is marked by this arrow, mid-parental height or target height. But you know that if all these biological variants they have a normal Gaussian distribution. So we add 8.5 and you subtract 8.5 to get what you call a mid-parental range. And I'll show you in the afternoon lecture, right? So it's not exactly the target height. You can be 8.5 centimeters more or less than that. So there's a different way to mark it. I'll show you in the afternoon. So you have to fall within your mid-parental height to say you're within your genetic potential. And for any little child after 2 years of age, we expect them to fall within their mid-parental height. Now, this chart is the CDC chart, which is mainly meant for Americans. So that is why we use the growth, the CHDR chart is the better chart for our population. This is just I took from the internet to make it, to explain the concepts to you, but we will look at it a little bit more detail in the afternoon. So that's for constitution, delay in growth and puberty. And then I have very few slides, we'll go through the causes for short stature. So you can have growth hormone deficiency.
Excuse me, madam.
20 minutes?
Yeah.
Thanks. I'm sorry, it's taking a little bit longer than I thought. There are some questions how to tell the number of the, okay, the 20, it's written on the chart, right? So there's a question, how to tell the number of the centile chart like 25th. It's written on the chart, right? So, yeah. Then if the mother was on steroidal therapy, like in a kidney transplanted mother, in her pregnancy period, does it affect the height of the child? Oh, that's a very interesting question. No, probably not. Yes, because the mother's genes won't be affected by the steroids. So I guess in that situation, that's extremely interesting situation. Now you can take the mother's sister's height or the mother's height or something like that, because certain genes will not be in that. That's an extremely interesting situation. I haven't encountered it actually. Then do we adjust for prematurity? Only up to 2 years of age, right? After 2 years, you don't adjust. So we only go look at the genetic potential after 2 years, so we don't adjust. So thank you for those questions. I'll quickly go back to, sorry about the time. We'll look through the slides quickly. These are the causes for short stature. Right, so you can have growth hormone deficiency due to, it can be either congenital when you are born with a small pituitary gland, right? So those are the classic symptoms. You can get hypoglycemia, jaundice, micropenis, midfacial hypoplasia, and midline defects. Those are just features which indicate you may have congenital growth hormone deficiency or multiple pituitary hormone deficiencies. Then sometimes children can develop tumors or growths like the craniopharyngioma, any suprasellar tumors which impinge on the pituitary gland, which can lead to acquired growth hormone deficiency. So these children may be growing normally and then they have very severe growth faltering, right? So the bone age will be very delayed and it's pretty dramatic. So they're very short, and so in these situations you can refer, and then the specialist will look at whether you need to look at their growth hormone. This is a child with untreated hypothyroidism. So I remember I told you about the in severe untreated hypothyroidism, you can have disproportion. When you look at this first child, so this was when she was 7 years old, right? And she presented. You can see that she doesn't look like a short 7-year-old. She rather looks like a younger child, maybe like a 4 to 5-year-old. That is because of the disproportion, right? So her upper segment is actually relatively preserved and her lower segment is short. When you start thyroxine, these proportions reverse. Also, you lose weight. And can you see now her trunk has got longer, her limbs have got longer, and she looks more like a 7-year-old. So this is what I meant. The younger you are, your body proportions are a very helpful thing. You will interpret it automatically. The upper segment to lower segment here is abnormal for a 7-year-old, but here it has become 1:1. This is just a pictorial thing so that you understand the concept, right? So in severe hypothyroidism, you have to look at the face of the child. They look very blunted, they have coarse faces, and you get a marked improvement. So this is the same child with steroid, with treatment with hypothyroidism. All this fat and the coarseness goes off, and they start gaining weight rapidly, height rapidly. Sorry. Right. So this is a child with Cushing syndrome. So these are just guides. So you have to look at the child. If the child is short, please look at the child. So this is a child with Cushing, and this is before he had Cushing's, right? So you get you have to see whether the child has any stigmata for Cushing's disease. Rickets is another cause for short stature. So you have to look for the typical features like widening of the wrist, right? Any chest deformities, all those, the rickety rosary, Harrison-Sulker. So you need to do a good clinical examination looking for the underlying reason. In Turner syndrome, you will have the facial features like a triangular face. You may have a webbed neck, right? A short neck, the low hairline and all these other features, right? So these are in young babies, newborn babies who have the dorsal edema. I've given you the features of Turner syndrome. Again, in any child who's short, you need to look at these. And if you suspect Turner syndrome, then you diagnose by doing a karyotype, which has only one X, a single X, if it's a full blown. You can also have a Turner mosaic, where the features may be less obvious. So any girl who's very short and you don't have a reason, we usually you can refer and we may consider a karyotype. Some of these girls may not have classic symptoms. Noonan syndrome, another syndromic cause, so we can quickly go through the features. Silver Russell, they are born with, they have low birth weight, right? And they have these other features which you can briefly look at. Triangular face, frontal bossing, clinodactyly. Don't need to remember everything, but just remember these syndromes and a few features so that you will remember if you see a child with short stature to look for these. So these are two children with achondroplasia. You can see their limbs are very short, right? So they look disproportionate. Actually, this is a girl with Turner syndrome, I think, with a normal brother. Right. So then how do you manage short stature? So at your level, very important, check the height yourself, plot the height and weight, and look at the mid-parental height. You plot it at 18 years of age on the appropriate growth chart. For all, it's the CHDR charts. Then you need to take a detailed history and examination to identify the underlying etiology. So what I've given you is lists of the underlying etiology, and you have learned about those conditions. So you need to, for instance, you need to look for features of chronic renal insufficiency. If you haven't, you will learn about them in the future. And when you come to your professorial, we will go through this again. And the other important thing of short stature is that short stature per se is not a disease. There are two reasons why it's important. One is it can be the manifestation of a chronic serious disease. Like I told you, they can have a brain tumor with severe growth failure. They can have hypothyroidism, which is easily treatable. They can have chronic kidney disease, which needs treatment, right? So the reason for the short stature is very important. It's very important to find this out. And the other thing is the psychological impact of short stature on this child. So most of these children, will depends, but half of them are okay, but half of them say they are bullied, they are called kota, right? So they are very unhappy in school, and this is a time where their peer recognition is very important for their self-esteem, especially when they start school. If they're the shortest in the class, it can affect their self-esteem. And also they are sometimes treated as younger children, which is also not good for their mental and social development. So they can have poor self-esteem, they can have school refusal. So we have to look at the psychological impact of this on the child. So the two things which children usually don't like are being the shortest in the class or having a younger sibling who is taller than them. That is also a bit of a self-esteem issue for children who are short. So as I told you, there can be serious underlying diseases. So you can start off after you plot the growth centiles. Also remember to plot the weight, and then you can do some basic investigations. All of you have access to this. You can get, if you have a radiologist, you can do a bone age and you can get a bone age assessment. But other things are very simple. A full blood count and blood picture, ESR, UFR, renal function test. Make sure you exclude renal failure and any chronic anemia, chronic infections, if the child, especially if the child is very short, right? If he's within the mid-parental height or it's just bone age is only mildly delayed, it's not that short, you can follow up. But if you suspect something is wrong, these are simple investigations. It's better to exclude any underlying disease. So things like Crohn's disease, inflammatory bowel disease, they also will manifest as a elevated ESR, right? So sometimes they're very hidden occult diseases, but they can manifest as short stature. Then thyroid functions could be useful, especially if they are a little bit short, they are having constipation, then you definitely need to do a at least the TSH. And if you suspect rickets, you can always do your calcium phosphate alkaline phosphatase level. You have to do it together, right? And if the alkaline phosphatase is high, phosphate is low, then you can diagnose rickets and treat them. Right. In any girl who is short with unexplained short stature, it's good to consider a karyotype. We don't do buccal smears now, so only do a karyotype to make sure they don't have Turner mosaicism. And if the child has disproportionate short stature, then what we do is we discuss with the radiologist and do a skeletal survey to look for radiological features of any skeletal dysplasias. Again, for you all can refer. So what you need to know is pick up if a child has disproportion. If it is disproportion, then you know the reasons are rickets, hypothyroidism. Those you can check by doing a TSH and a calcium phosphate alkaline phosphatase. If those are normal, then you can refer and we can get a skeletal survey done, seeing whether this child has skeletal dysplasia. So this is a very nice flow chart I borrowed from someone else. You can quickly have a look at it at your leisure time. And if you have anything you don't understand, you can discuss in the next session, right? So this is all we discussed given as an algorithm. If the child is very short, then we suspect growth hormone. Again, you can refer. And the screening test is low IGF-1. So if IGF-1 is also low, then we go ahead with a growth hormone stimulation test. And if that is also low, then we usually image the brain, the pituitary region, to see whether the child has congenital hypothyroidism, hypopituitarism, small pituitary gland, or a thing like a suprasellar tumor. Then how do we manage short stature? We follow up. It's very important follow up, checking how they grow. And if it is, the child is not that short, the basic investigations are normal and the child is growing normally, though he's short. If his growth is along a centile line, then usually we can reassure, but remember it's better to follow them up, right? At least once a year, make sure they're growing along their centile line. And the definitive management will depend on the underlying cause. So if you have pathological short stature, then you need to treat the underlying cause. If you have familial short stature, there's nothing we can do. So just reassure and follow up that they don't have anything serious. And then constitutional delay, again, we can reassure and follow up. So these are just indications for growth hormone therapy. You can quickly go through them on your own. And then few slides on tall stature in childhood, which is hardly ever a problem for the child. So one, if you have very tall parents, you can be tall. Other things are more like postgraduate conditions. You can have early puberty. You can be very tall. If you have excessive androgens, like in congenital adrenal hyperplasia, if you have a tumor producing growth hormone of rarely, if you have hyperthyroidism, it's uncommon, but these are causes for tall stature. And then you may have already heard about syndromes like Marfan syndrome and Klinefelter syndrome, where you are tall, right? So that's a little bit too much, but just remember these causes. So these are just what I have. For the remainder is slides of syndrome. So Marfan syndrome, what are the features, Klinefelter, just to recap what you may have already learned in genetics. And finally, we have overgrowth syndromes, again, more postgraduate things, right? So if you have a baby who's very large from birth, we suspect with a very large birth weight, maybe 4.5 kilos to 5 kilograms, and they grow excessively, then there are genetic conditions like Beckwith-Wiedemann syndrome and Soto syndrome. Right. So that's all for this lecture. If you have any questions, you can ask on the chat box. Okay, so I'm sorry I had to rush through a little bit, right? So the concepts you need to remember are getting a proper weight, plotting it on at the correct age, correct chart, checking, also plot the weight, right? And the mid-parental height. So I want you to look at the mid-parent flight and do it yourselves and plot it on a CHDR chart, which you hopefully you all have. And then when we do the puberty lecture, we will just look at that, because we will again be talking about constitutional delay in puberty. And at that point, I will explain it a little bit further. Do you all have any questions? Right, then about the puberty lecture, which is scheduled for the afternoon, what time do you want to do it? Luckily, I don't think we had any connection issues today, but I think it will be better to do it in the afternoon. You all have more experience with the internet